Welcome, everyone. This is the September meeting. I was about to say August, September meeting of Plan, Design, and Expenditures. We're just letting people in the room, and we'll get started in a minute.
FYI, I am getting a message that I can't use my camera because the host has blocked it. This is Jamie.
Thank you, Jamie. It was nothing personal. Just unblocking.
Great. Welcome, everyone. This is the September meeting of Plan, Design, and Expenditures. Excited to have you all here. We have a great meeting today. We are going to be doing some quick presentations on a variety of different topics, and we're going to be meeting our new consultants. Milliman has signed on officially and is going to be participating in our work from here on, and they're going to be the major consultant working with the Plan Design Group, so we'll get to hear from them today. And then we're going to have some quick presentations about emergency transportation. We're going to revisit behavioral health briefly to kind of talk through some things that we've worked on since we last discussed it. We're going to talk a little bit about a quality strategy and then hospital payments. These are mostly informational at this point. There's not going to be any proposals we anticipate coming out of these discussions. It's just to sort of introduce a couple of these ideas. And then we're going to do breakout rooms. We've done this at least twice before, where we're going to let the committee members split up into breakout rooms according to the topic that you're interested in. So we don't have to fill all those topics, but those 4 topics will be available if you're interested in diving a little deeper, having a more in-depth discussion on those. We'll have time for that in the second part of our meeting. So it should be a packed meeting, really interesting, bunch of different topics. So with that, let's get started with a roll call.
Great. Helen Belanca.
Here.
Thank you. Chenwei Chi, does not look like he is here. Peter Addy.
Here.
Thank you. Gabrielle Endine.
That's me.
Thank you. Betsy Boyd Flynn.
I'm here.
Thank you. Mike Durbin.
Here.
Thank you. Rob Fizzette. I did not see Rob in the attendee list. Tony German.
Here.
Thank you. Eve Gray.
Here.
Thank you. Rosemary Hemmings.
Here.
Thank you. Julianne Horner.
Here.
Thank you. Max Kaiser.
Here.
Thank you. Jim McGee. I didn't see Jim yet.
I think Jim may have to join later. He said he was going to be out for a little bit. Excuse me.
Yep. Peter Merritt. Don't see Peter yet. Angela McKillick.
Here.
Thank you. Jamie Osborne.
Here.
Thank you. And Tosh Rahman.
Here.
Thank you. That's everyone.
Excellent. Welcome, everyone. At this point, I will pass it over to Mimi to do a review from our previous meeting and then committee and board updates.
All right. Thank you, everyone. I'm Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. I will briefly give some updates. So first off, at the last meeting when you all approved to send up to the board the primary care provider payment preliminary proposal, the board reviewed it and the proposal was approved on August 21st. Just some feedback from the board. One board member voiced concern about administrative costs and expressed a preference for fees for service, although that board member did vote yes to approve it. And then there was also the request for verbiage added to include some allowances for particular circumstances that would have exceptions to requirement of that specific payment model. So that was one big thing. And I think overall the board was incredibly impressed and grateful. Sorry, I won't speak for them, but certainly staff was. Next, of course, we talked about Connecticut Medicaid at the last meeting, and also some Maryland hospital payment systems. So I am now going to turn it over to Tony German, who is going to talk about the conversation that he and I will be able to have, and other information about the Connecticut Medicaid program. So if you go to the next slide and take it away, Tony, thank you.
Yeah, good afternoon, everybody. Thanks, Mimi. This arose just some follow-up emails and conversations with the director of the Medicaid program, Bill Halsey, in the state of Connecticut, and then had another meeting with the former director, Dr. Deidre Giffords, and reflections of what's occurred in their Medicaid space over the last decade. And just a few quick slides. We have a lot to do today, but wanted to give some feedback on kind of the observations and the shared information they've had, and some research that kind of pulled. Some of the highlights that they brought up were some of the successes. Certainly, we've talked about this as far as the cost savings and removing administrative inefficiencies. They did demonstrate that their access to care actually has continued to improve comparatively to the national benchmarks. And a standout really is their quality metrics when compared to national data. Demonstrates that transition didn't falter in their ability to maintain high quality care in the state of Connecticut when they moved from a managed care organization to that of an administrative, an ASO. Some of the challenges, I think probably the reflections that particularly the two of them shared was that not largely, but some of the reasons they've been able to reduce costs is that their provider reimbursement has largely been stagnant over that time period. They are adopting some changes to be competitive in that space. And actually in their legislature, they just passed that. So that will be moving up. If they gave the recommendation, should any state move in this direction, that certainly having a rate evaluation system in place, that was some of their learning points that they shared with that. I will also note in some of my learning, it seems that in 2023, actually the state of Minnesota has intentions to move this direction as well. So they have not formally adopted that, but they did put in place in 2023 legislation to move from a managed care organization, which is interesting, being the home of really some large players in the marketplace for commercial insurance and managed care organizations. And we'll talk a little bit about some of the reasons of that. We can jump over to the next slide. So the origins of this transition is nothing new probably to many people on this call, as far as the troubles that they were observing with their relationships with the managed care organizations. Is there was a great deal of uncertainty, a lot of difficulties in communicating and coordinating care, and confusion between the healthcare providers and that of the beneficiaries. That led to problems with timely payment, inconsistency in the rules, multiple difficulties with prior authorizations, formularies, such of that nature, and really just a large opaque system. And so that led to legislative efforts that led to their transition for simplification to remove some of these administrative burdens that they were observing. You can go to the next slide. So with that, they elevated the intention of this transition was to provide a structure that had uniform policies, that was one source to communicate, a single entity that providers could connect with. Again, eliminating some of the barriers and some of the limitations that the healthcare providers were observing with their relationships with their patient care. And providers no longer needed to navigate, the duplicative rules and requirements of the different managed care organizations. Just a reminder that when they did this transition, they have one ASO for physical health, for mental health, and for dental health. Then you go to the next slide. One observation over time is that they did see broader engagement from the provider community. And so they did see an uptick in provider satisfaction, which probably led to people wanting to be involved in the system. So you had more people coming into Medicaid rather than leaving Medicaid as healthcare providers with their satisfaction. There's just a brief kind of score there. And comparatively to national benchmarks, this is quite impressive that you have such a high, very satisfied or satisfied, upwards of 97% of providers that work with the Medicaid ASO. We can go to the next slide. Again, this led to really a direct impact. Dr. Giffords called this out. Within the first 1 to 2 years, they really saw a number of providers wanting to be involved in the program, which was a dramatic change from their prior efforts. As I mentioned, the provider enrollment increased from just about 1,600 in January 2012 to 2,370 by 2013. So really a significant increase in that first time period. Go ahead, next slide. The other thing is just not looking just only at primary care, but also in the specialty care area. There was growth there in the Connecticut program, the Husky program. And so you continue to see that rise in 2021 to 2022, more recent numbers with that. So significant expansion in increasing access to specialty care for the Medicaid beneficiaries. Next slide. One of the tools that they have leveraged, as far as we're going to talk about quality today too, is essentially a pay for performance program. So Connecticut's ASO contracts include accountability mechanisms that look for population health measures. So a percentage of each ASO's administrative payment is withheld pending achievement of those benchmarks that we're pretty familiar with some of our CCOs and with those quality metrics, such as like how are we doing with our diabetes or hypertension. And so they work hand in hand with that in order to ensure good quality outcomes. So just want to give some feedback. I think that's our last slide here.
Tony, it looks like Helen has her hand up. Oh, and Jamie.
Tony, is the reason why the provider engagement increased so much, was that the simplification, or did they raise rates, or both?
No, actually, they did not raise rates over 10 years. So it wasn't because of increased payment, which is the interesting feature with this. Yeah. That has changed. Like, as I mentioned, they have accommodated to that and they're implementing increased payments. But I think that was some of the piece of how they've kept costs constricted. And it really was, I think, providers finding a system that worked better for them. Is the reflections that Dr. Gifford and Bill Halsey provided to us.
That's impressive. that much satisfaction just from administrative simplification.
It makes sense, though. Jamie?
I have two questions. One is, Connecticut's pretty small, and so it makes sense that they could have a single ACO and administer that statewide. Where we had talked before about maybe there's some benefit to having some regional entities that can advocate or tailor how they do it depending on whether they're urban or rural. And so I wanted to ask if you had heard any reflections on that, or as you were processing this, if you think that's a thing. Then my second question is maybe crazy, but could this be an intermediate step to universal coverage rather than the method by which we administer universal coverage? It's just a thought I didn't have at all until I listened to you talk about it. And then I thought, as we're thinking about the next couple of years, could that be one of the proposals to say, like, maybe this is a step toward that would be less painful?
So just the first point, just peeking again over my shoulder here, looking this up. So the state of Connecticut has 3.6 million individuals in it. We have roughly about 4.2 million. Their Medicaid population, I think, is around, actually, I have that right in front of me, but I think closer to 600 to 700, where ours is kind of closer to 1.2 million as far as expansion. Yeah, I think the model, I think that's a good question, Jamie, with regard to focusing really on our Medicaid population. The challenges I think that we're actually going to see with the HR1 withdrawal funds, that we're still going to have trouble with maintaining doors open if people are dependent on Medicaid. And I think simplification, any direction is ideal. So I think that's great. I don't know if I should, my personal concern would be, I think would be incomplete. Gabe?
Thanks, Tony. Thanks for reviewing all this. This last slide that you've got up there, this is interesting to me to think about it, how they tied some of their administrative payments to provider experience and satisfaction. That sort of thing. You'll forgive me. I've grown a little skeptical or cynical of how things may look on paper versus how they actually execute in the real world. And I wonder if you got any sense talking with them about how this particular element of the structure has played out in terms of the connection between, how people are scoring and, are people's payments really being withheld or impacted by that? Do you have any sense?
I can't say that we had a great deal of information, but it would be one of my follow-ups and an interest that I think we could, engaging with Dr. Givers and Halsey, they were very supportive of if we had follow-up questions, and we could follow up with that.
Thanks.
Can I just jump in on following up on Jamie's question about regional entities? We have not made any final sort of decisions about regional entities, but you're right. We had talked about divvying this state up, and that might work better in Oregon given how different our regions are. But one thing we could consider is that even though there are, however many, 6 to 9 regional entities, they could all follow the same rules. Like they wouldn't be allowed to have different rules about how billing is done, how payments are done. They would all follow exactly the same rules. So if providers worked in different regions, they wouldn't be dealing with different, like that administrative simplicity is what's really key. So we could keep that the same and just have them tailor the healthcare needs around their individual region, but not have them be administratively different. Thank you, Tony, for following up on this and bringing this information back to us. That's really helpful. Mimi, do you want to go ahead with committee updates? Mimi, are you there? Oh, looks like Mimi has left. Isabel or Lee, are you there?
Yes, we
yep.
are.
Okay.
Yeah, it looks like Mimi's having is frozen on her end.
Okay. Let's give her a few minutes and we can move on to introducing our Milliman consultants. Is Ken Laskowski available? Is he?
Yeah, I'm right here.
Awesome.
Do I have the ability to share PowerPoint?
Yes. Yes. So, Ken, I'm going to leave it to you to do a quick introduction of Milliman. We're so happy to have your team on board, but go ahead and introduce yourself and your team.
Absolutely. All right. Can everyone? Oh, I gotta hit the share button, huh? Can everyone see this?
Yes.
All right. All right, Fritz, are you here as well?
Yes, I am.
All right, so my name is Ken Laskowski. I'm here. I'm a senior consulting actuary with Milliman. I've been with Milliman for over 20 years. I have a lot of experience in macroeconomic projections, modeling healthcare reform changes. I've done that for numerous agencies over the years. I've assisted in 1332 waiver developments, including assisting with basic health plans and modeling that. And I've been pricing and generally active in the ACA markets and the commercial markets. ACA markets since inception since 2014. So I'm here to support the Plan Design and Expenditures Committee. With me here today is Fritz Bush. Fritz, Fritz is involved with a number of committees. Do you want to introduce yourself?
Sure. Yeah, Fritz Bush. I'm a principal and consulting actuary with Milliman. I've been with Milliman about 10 years, so not as long as Ken, but I've been in the business about 33 years. So I've spent most of my time outside of Milliman on the plan side, so working for carriers. But joining Milliman, I have found myself doing very similar to Ken, a lot of state-based healthcare reform related work, which includes a lot of the things that Ken listed. So things like waivers and universal health plans or partial universal health plans. We've worked in states like New Mexico, Minnesota, Nevada, quite a few number of states doing related work. This is obviously the most ambitious project that we have helped support, but it's exciting. And as Ken said, I'm the overall project lead. I have hired some of the best in Milliman, who are our leads for a couple of the other work streams. Kate Shadell is heading up the operations and administrative team and supporting them. Oh yeah, very good. Thank you, Ken. And Ken is really the lead for the plan design and expenditures work team, this crew here. And then we also have another gentleman named Massey Worley, who's going to be working on the economic modeling. So with that, let me pause if there's any questions, and then I've got one slide that I'm going to share, then I'm going to let Ken jump in. So any questions for Milliman thus far? All right, Ken, do you want to move to slide 5 there? So I just want to very briefly talk a little bit about the overview of, I've kind of went over it a little bit already in terms of how we've staffed for this project, but generally we are supporting this project in your goal of getting the required legislative report by September of 2026. So our analysis, along with and by the way, this is my understanding, so please people can feel free to correct, especially Mimi. But the way we see it, this slide could change, is we will be supporting that total effort. In terms of putting that report together, our content will be, significant portions of that, which will include, the reports that will go directly to the plan design and administrative. Oh, no, I'm sorry. Plan design expenditures. Sorry about that. Committee here, the finance and revenue, and that particular work stream is going to be done in conjunction with Morgan Shook, who has been doing the really the tax modeling and the revenue modeling. So we're actually meeting with him tomorrow to coordinate some things that we need to coordinate, for this final report. And then, of course, the operations committee, we have a lead for that, and those will all of those separate reports will be appendices in the main report that Milliman will help support the production of that. So that's a little bit about how the pieces of our engagement with the UHP will look. And certainly, if there's other conceptions of how we want to have Milliman's engagement look, please let me know. So you might see this slide frequently. It might change a little bit as we do our reports to each of the committees. So with that, I'm going to have Ken go into a little bit more detail about how he's going to handle some of the deliverables and analysis for PD&E.
Yeah, we have so our big main deliverable at the end is going to be the written our written report in February and March here. But we do have a couple other things we'll be helping with along the way, some technical guidance, help with the savings assumptions, our thoughts on that, and any advice you really need on additional strategies. But I wanted to give just a kind of approach, generalized approach, very, very, very high level on how we do our work and how we get there. So we're still in that first phase right there, just engaging with the committee. We're doing a little bit of catch up here to the great work that you've already done. Fritz and I have been able to watch some of your videos and listening to some of your for example, the provider reimbursement discussions. So our job really is to as decisions are made, our job is to figure out how we're going to model those and turn those quantify those into changes in expenditures and changes in costs. So how do we get there? Our first item, one thing we're working on right now is we're developing a baseline census. Essentially, where is Oregon now? Those 4.2 million people referenced in Oregon, where are they? How do they have? What is their coverage? How rich is it? After that, after we fully understand where Oregon is now, we're going to be building our model. We are also concurrently building that model. So the tough part for us, I think, with building that model is really balancing the complexity of the model with transparency, and also with how detailed do we make it versus how generalized do we make it. Then once we are producing results, we go, how do we effectively present those to all of you? How do we communicate those results? And how do we work together to really figure out and hammer down what goes into that final report, from us, and then how do we help you from there going into the final report to the legislature. So getting into that baseline, our kind of our first step in understanding where Oregon is right now, we're really trying to understand the current healthcare by market. And when we talk about market, we're referencing large group, public employees, the Oregon educators, other public, small employer, individual, self-funded, Medicare fee-for-service, Medicare Advantage, Medicaid, CHIP, and those other ones at the end there. And we really do need to look at them each at that level, because what goes into that baseline is enrollment. So within each of those markets, where are people enrolled geographically? Are they by county? So are they rural? Are they urban? What is their approximate income level? How does that vary in case anything down the line in terms of be it funding or whatever comes through at the income level? And then demographics, age and gender. What is the age and gender makeup of everyone? And then we're looking at each one of these. Then we're looking at costs. Each market has very different benefits and plan designs. Going forward to the UHP design, it's very rich. It's based on the public employees plan. That's a lot. What's offered in that plan is a lot different than what's offered in, say, your bronze ACA plan or Medicare, for example. So we really need to hone down the types of benefits in each market and what the average plan designs across the populations are, and really how that influences utilization. So we need to understand. We're doing research and we're developing current utilization, so current, hospital admits, PCP visits, et cetera. We need to be looking at that. Also developing at this start provider reimbursement. So how much are physicians and hospitals paid? Because that does vary pretty widely by market in your baseline. And you guys have already done some work on looking into different provider reimbursements, but conceptually, it's so easy to understand Medicare. Medicare is 100% Medicare. It's set by CMS. Conceptualizing the commercial market is much different. It is, certain services in inpatient hospital might be 200% Medicare. Outpatient hospital might be 250% Medicare. Then physician is different from that. So we have a lot of data. We have a lot of transparency work. We have a lot of benchmarking data to help us understand immediately where Oregon is at right now. And then the final piece of that baseline is administrative expenses. I'm not going to go too much into detail of that. We just need to know where it is right now. We're working with the operations Milliman team on that. And then that kind of becomes their problem, for lack of a better word.
Ken, let me, sorry, I'm going to lower my hand. I don't know if you saw my hand raised.
No, I didn't.
Just one comment. If you, a couple years ago now, I suppose the Optimus report was the original report that I think was not, I don't know if it was a part of this particular committee. I don't know the full history.
No.
It was not. Okay. Well, they took a very similar approach. I read through that report. Our attempt to improve on the transparency of that is all of these things that Ken talked about here. Let's just take provider reimbursement because it's the easiest one to understand. Can be indexed to a 1.0. And you can put everything on a 1.0. That includes benefits, right? So you can pick, the public employees plan would be 1.0. Everything is indexed to that. So anything that is going to affect costs under the UHP, this would include the things that Ken's got here, some of the utilization changes, provider reimbursement, benefit plan design. We had a couple other ones that I'm not thinking of right now. We're going to put those in terms of indexes. That way you can look at all these things, and then we'll keep the number of these things to a manageable level. Like Ken said, there's about 8 billion things that you could try to model. But we don't have that time. We don't have the intellectual capacity. I shouldn't put it that way. The board is going to need it simplified. Let's put it that way. I don't mean to say that at all. I'm sure that intellect has nothing to do with it, but the point is they're going to be digesting a ton of information. So we're really going to try to make this as easy as possible and use indexes so that they can see relative to a baseline what is happening between the baseline that Ken's describing here and then ultimately to the projected amounts. So
yeah, thanks, Fritz. Can I jump into, just for the committee's benefit, what he's referring to is the task force that preceded this governance board, contracted with Optimus, a different consulting firm, and they came up with a model for how much it would cost to give everyone in the state PEB benefits. And they gave us a number at the end. It'll cost this much, and here's where the savings will come from. But it was a model that we couldn't play with, for lack of a better word. So if we said, well, it's going to cost that much, but we don't think we can generate that much revenue, what could we change in the benefit package so that we can cover, this basic set of services? So I think, Fritz, what you're saying is, in the model that you're developing, we'll have a PEB benefit. We've all decided that's the benefit level we'd like to give to everybody. And so we'll see what that looks like and how much it will cost. And then if we want to, we could play with things. We could take dental out and put it somewhere else, right? Or there'll be big chunks, like you said, not a million things we could change, but sort of big chunks that we could remove and say, how would that affect costs? How would that affect the overall plan design? And so we'll have a few more options of what we want to ultimately recommend.
Yeah, and I would add for the committee just to, understand that sort of the scope here, and maybe you're familiar with this. Like just basic back of the envelope math, you're talking about a $50 billion healthcare program here, roughly. It depends on who you ask, but if I just did it on the back of an envelope, that's roughly what you're talking about here. So when you consider it that way, we're talking about adjustments here where 1 billion is 2%, right? So that should help us understand, what kind of levers do we want to build in here? Do we want to build in levers that are only going to change the dial by 1 million? No, we don't.
Right.
Because it's irrelevant, right? So
Right.
that should tell you the approach that we're taking, and the things that we've listed thus far. These are the big ones, right? These are the ones that are going to get you a billion here, a billion there, a billion here, and a billion there. So, that's kind of, and then just a note on the administrative expense is I think it's not really part of the, I mean, this is sort of an add-on that we're doing, but I think it's going to end up being of interest for the Administrative and Operations Committee is, how much are we spending on admin now under the current system, right? So that serves as kind of a benchmark, like, okay, well, if you're spending, 5 billion on admin currently, what do we think this is going to cost under UHP? So presumably it will be less because you won't have duplicative functions. But that's really why, and then of course you eliminate things like risk margins, taxes, and fees. So that's really why we're gathering that is on the baseline. We want to at least understand what's being spent now.
Right. And the Finance and Revenue Committee has really pressed this point. The Optimist report estimated that there'd be like between 4 and 12% administrative savings with the UHP compared to our current system. But that's a pretty big range. Like Fritz said, 2% is $1 billion.
Yeah.
And the task force that preceded us conservatively estimated 4% administrative savings, and that's how they came up with their numbers. So again, it would be interesting to see what are those administrative expenses, what are we reducing, how much more could we reduce, what would that mean in terms of how the plan would function, and just to dial in that a little bit more specifically.
Yeah. All right, go ahead, Ken. Sorry, a bit of a diversion there, but
Yeah, then just to go a little bit further into the modeling process, once we understand that baseline, we have this kind of intermediate step here where we have to project to 2030. And then we'll create from that essentially 3 scenarios. Status quo being if the UHP is not implemented, and we may, I mean, put UHP, UH1 and 2, but there may be more than that. Yeah, there's going to be several iterations at least, and we'll get into that a little bit. But that intermediate projection, kind of what happens from 2024 to 2030, is important, as is once the UHP is implemented in 2030. So how do we model those changes? What are we thinking about in terms of changes in enrollment? So we look at population shifts, population growth. So reference, how from that 2024 to 2030 period, some of our starting data here is, from years 2022, 2023. There's already a lot that's happened since then. Oregon started their basic health plan there. The ACA markets in particular are experiencing big shifts. So we need to project how membership is going to change. So are more people going to move to uninsured markets, and what is their makeup? And then as we start to think about the UHP, we start to think about eligibility and what kind of population is that going to bring in, and medical tourism, what kind of population is that going to bring in, and how do these population shifts, how do they influence demographics, such as age and gender. Have a pretty big impact on overall claim costs. So if for some reason we expect the population to get a lot older, costs are going to go up. Also need to think about income level changes and geographic, rural, where are population changes occurring.
One thing I would add here, Ken, if you just go back real quick,
Yeah.
I think the biggest one, if just to emphasize this, and you're going to start hearing from us more on this particular issue, and that is, and we're willing, we are very much willing to listen, but I got to get this out there as sooner rather than later. Is this issue of medical tourism? That maybe isn't the right word for it, but there is but we should maybe change it, because it's not really that people would be tourists. It's that they could change state locations for the purpose of obtaining health coverage, particularly in border states, but it could be from just about anywhere. And if that happens, to Ken's point about the demographics there, then that potentially starts to shift. If people have a very large condition where they know they're not going to be paying very much in taxes, they would probably take the tax increase to move to Oregon, maybe from another state, Idaho, I don't know, because it's well worth it to have, you know, a medical care of say $100,000 or more paid for. So this is something that we are definitely going to have built in to some degree. This committee, we will have to discuss the degree to which we think this is going to happen and the severity of it. So there's going to be a volume impact. How many people are going to do that? And then how do we think those people's health costs will compare to the average?
And then I want to just discuss how we're going to model changes in cost, which can get pretty complex. There's a lot to think about. So we're talking earlier about the baseline, benefits and plan design. So benefit changes. How are members going to, how are individuals in Oregon going to experience benefit changes? So, for example, in Medicare does not cover dental. Dental is one that if all of a sudden a lot of people get dental coverage, how is that going to impact costs? And the richer plan design. Our job, part of our job here, is to evaluate EHBs in ACA versus Medicare versus Medicaid as they get to that richer plan design. How is that going to influence costs? Because what it also influences here is utilization. Um, it's generally, as a plan becomes richer, you see increases in utilization, and this is even down to say something like a copay, a PCP copay. As an individual has to pay less, they utilize more and they go more. So you're going to expect anyone with either no coverage or less coverage to utilize services more. So we have our the minimum health cost guidelines. We have a number of sources that we're going to use to evaluate exactly how much utilization is going to increase as the plan gets richer. And kind of on top of that is maybe more short term, rather than just shifting from like a 70% actual value plan up to this rich plan. What is pent up demand? So dental is a great example of pent up demand. If someone hasn't had dental in a number of years, the second they get it and they have no cost sharing for it or something to that degree, they're going to go in, they're going to get every toothache they've had for the last 5 years fixed. So that's also part of our quantification.
I would add on the dental piece, obviously, if the Universal Health Plan is contemplating, which it is right now, is my understanding, coverage for Medicare beneficiaries, dental on Medicare is even more expensive. So that's a bit of a double whammy there.
Yeah. Then provider reimbursement. We talked about the varying provider reimbursements by market. So as UHP is going to that policy is going to set overall reimbursement levels. So if we shift from all these differences in these markets to something like 120% of Medicare inpatient, how will that impact costs overall? Then just quickly go through cost containment. What are the different what are the strategies related to current cost containment measures versus what the UHP is going to implement, as well as medical management. And then we also have to consider just general changes in medical and drug costs, trends. We haven't really discussed drug costs at all, or formularies. Formularies differ by market pretty extensively. So how are drug costs and drug prices in general going to change? And then how might some of those population shifts impact the health status in Oregon?
I would add on the medical management. We've had we talked a little bit with Mimi about this. We won't be really doing any modeling per se on which medical management protocols to use, if any. However, our reporting will contain commentary about current. So again, built into the baseline, built into the projection of the status quo in 2030. There are assumptions in those claims costs about medical management that is currently taking place. So we will comment on the impact that it could potentially have if whoever the TPA is who's administering the UHP does or does not do similar medical management tasks that such as disease management or prior authorization or things like this. So just to be aware, we have expertise in that area. We can comment on that, but we won't necessarily have like distinct modeling on that in the paper.
Yeah, and just I'll quickly go to the timeline since we're a bit over here. But we're doing our baseline and our model construction now. We're gonna be doing our projection, our status quo projection, and our UHP projections in October, with the hope that we're gonna be doing essentially the first round deliverables either late October or sometime in November, just to give this committee and to give stakeholders in the UHP governing board enough time to react and understand our results, because I think we're going to need a few rounds before we really get to the projection that informs our final report in early 2026.
Mm-hmm.
And that caveats, and then that's it. Thank you.
Thank you so much, Ken and Fritz. That's fantastic. And I hope all the committee members can appreciate, as the staff and I have, how great it is to have them on board. We're really excited to be able to work with you. And this committee's work and Milliman's work will be deeply integrated. And so we will keep coming back to you with updates about that. But thank you for being here today and, of course, participating with us in the future. I'm going to pass it back to Mimi for some committee updates.
Right. Thank you, guys. Sorry, I'm even in my downtown the Dalles office with alleged better Wi-Fi, but nothing is perfect. So very briefly, I already mentioned the board passing the primary care payment proposal. So that was approved. Board working really hard on evaluating the revenue plan that Finance and Revenue is coming up with. And so they spent a lot of last meeting, and the next upcoming meeting, they will be doing that. Also working again on the organization structure of how the independent corporation, the administrative functions of it, and truly how it is formed. And again, as Helen was mentioning, bringing in that sort of the aspect of regional portions of the corporation or regional entities. Excuse me. Next, community engagement and communications has done amazing work. They've developed a strategic communications guide, which is not quite ready for prime time, but oh so close. Also a couple of one-pagers that really describe very succinctly what the work of the Universal Health Plan is, and then some that have a little bit more detail. So operations, as mentioned, Milliman is lending a big hand there, looking at administrative structure, also looking at IT needs and costs. And then last meeting, we had another discussion around waivers, particularly the 1331 and 1332 waivers. And lastly, as I mentioned, Finance and Revenue really hoping to wrap up a core proposal of the revenue plan that should be coming up in about a week and a half. And also after that, it'll be an iterative process. However, they'll continue then working on the impact of that plan on individuals and employers. And as mentioned, Milliman will also be doing that status quo and the potential, working on that cost target, which may be a little bit of a moving target. So That's it for the board and committee updates. Thank you. Any questions? Sorry, that was my speed talking.
Thank you, Mimi. Okay, so we have a couple of presentations. I think it was incredibly important and useful to give Milliman more time today to talk about how they'll be working with the board. So we're going to make a quick adjustment to the agenda. We're going to save the behavioral health updates to our next meeting in October. And so I'm going to hand it over to our policy advisor, Lee Hastings, to talk about emergency transportation. And Lee, go ahead and take 20 minutes, and then we'll go to the quality strategy piece.
Just for one second, I don't know if you can see, Tony has his hand up, Helen.
Oh, sorry, I didn't
Just
see.
gonna pop in there.
No, sorry about that, Helen.
Yeah.
Just quick question. I'm really thrilled by Milliman, and thank you, Ken and Fritz, for your presentation. I think this is where the rubber meets the road, right? And so I am curious, Helen, just the governance board's thoughts, what it looks like, gather a baseline, and then consider a couple of different proposals, and then work a little bit to tinker with the benefits package with that. And is the board, maybe it hasn't been defined yet, but a couple offerings of different ideas with regard to what a benefits package and everything we're walking through, is that anticipated what will be offered September 2026? Is that it might not just be one plan, but it might be 2-3 different ideas of a plan as far as a benefits package and what that would cost and how that would be proposed.
Yes.
Okay.
So I'm anticipating that both from this committee and then ultimately from the board to the legislature, that it won't be like, here's the thing to do, this plan. Our recommendations from this committee up to the board, and then the final recommendations from the board to the legislature will include what everybody wants, which we've nicknamed everything for everybody all the time. So if we got everybody have benefits and we did really what we want to do, like what we think is the best benefit plan for everyone with enhanced behavioral health, here's what that would look like. Here's this, we'll deliver on that plan. And then here are 2 or 3 alternatives that would consider reducing costs, changing benefit design, just restructuring it a little bit to give people alternatives to consider. Yeah. And
that's great. Thank you.
Yeah.
Yeah. No, just and then with regard to that, with reference to what we talked about earlier today is just pure fee for service versus value-based capitation and all things go with that. I shared this the last meeting, my reservations completely adopting, and I think that was a straw proposal. But I would encourage, since we now have actuarial analysis, I think that those are the things that might be worthwhile to evaluate. Do when it comes down to the cost and some simplification of the system when we're thinking of administrative, reducing that administrative waste and inefficiency. It's something to consider when we pair that with, our leveraging quality and his pay performance and those things. Anyway, really exciting work, really excited to have that and to move us forward.
Great. Okay, I'll pass it to you, Lee. And go ahead for 20 minutes.
All right, thank you so much. I will keep a close eye on the clock here and talk quickly. So these slides will be available for your reference if you do miss something. I was asked to look into emergency medical transportation. This is my first foray into this, so I look forward to finding out what follow-up questions you have. This turned out to be a particularly fascinating topic, so I'm really excited to share this information. So just starting with kind of defining what we're talking about here. In this presentation, I'm really focused on emergency medical transportation services. So these are services, for patients that need to get someplace with a higher level of care than where they're located, which is typically the home or perhaps a workspace. These come in 2 flavors. There's ground ambulance services, which account for most of it. And there's also air ambulance services. For most of this presentation, I'll be referring to sort of the ground ambulance services, just due to kind of the direction this presentation ended up taking. Next slide, please. All right, so just starting by trying to get the feel for what does emergency transportation even look like in Oregon. It is part of our EMS and trauma system, and it's really pretty fascinating. It's pretty old, and there's a lot of different things going on here. So one of the first things that I noticed looking into it is there are a lot of parties involved. So according to the legislative statute here, counties, cities, and rural fire protection districts all have some authority to regulate ambulance services. And I just wanted to get a sense of how many parties are we talking about? Well, in Oregon, we have 36 counties. We have 241 incorporated cities. That number is about 100 more if you look at unincorporated cities. And as far as those rural fire protection districts, it turns out we have 261. So there are a lot of parties potentially involved in this. Next slide. But when it comes down to the rubber meeting the road, as it were, it turns out that counties bear the bulk of the responsibility. Counties need to have an ambulance service plan that is submitted and approved by the Oregon Health Authority every 5 years, including a whole bunch of information. Now, what's interesting about this requirement is it's not particularly well followed. So kind of in keeping with the fact that our EMS and trauma system is pretty outdated here in Oregon and kind of falling behind. So of our 36 counties, on their status tracker, 8 are listed as overdue, 9 pending county action, which doesn't really seem to be much different than overdue. And I'll say that of those 17, 13 of those plans are more than 5 years overdue, which means it's been 10 plus years. And some of those plans were last reviewed in the 90s. So it's really all over the place. This map, unfortunately, about the best map I could find related to ambulance services in the state of Oregon. The size of the dot basically references how many different ambulance providers are in that area and kind of gives you a sense. Heavy concentration, of course, in the Portland metro area. And as we look out to Eastern Oregon, a lot of those counties have somewhere between 1 and 3 providers. Next slide, please. Now, the good news, after finding out just how old and kind of outdated our EMS system is, in 2024, the Oregon legislature did pass an EMS modernization bill intended to really do some much needed overhaul of the system. This is their schedule. However, from kind of looking online, they are taking a little bit longer to kind of get their committees stood up, which is to be expected. So they have not actually started holding meetings yet, unfortunately, but will be something to keep an eye on. Next slide, please. Here is the specific tasks that are laid out. I'm not going to read through them because the takeaway is really down at the bottom, since I'm focused on emergency transportation, which is that this bill does not address emergency transportation. And I found that pretty disappointing and a huge missed opportunity. But then I did discover, actually, the intention was to pass a Modernization 2 bill in the 2025 session. Unfortunately, that bill did not pass. It died in committee. Possibly just due to a lack of attention, it seems. There actually was no testimony in opposition to it. But as a result, while there is some EMS modernization going, we're not talking about transportation at this point in time. And I will return to this in a little bit, but next slide. All right, so the next key thing I really wanted to understand is how is medical transportation reimbursed? And this, I don't know, maybe I'm naive, but it really sort of blew my mind because basically EMS does not get paid unless the patient is actually transported to the emergency department. And I just found that absolutely fascinating. Their reimbursement has 4 different pieces to it. You get a flat rate just for doing the transport. There's a modifier based on whether the unit happens to be advanced life support or basic life support, some geographic modifiers, and then a per mile fee. So of course, if you are transporting someone 100 miles, that's a bit different than if you're transporting someone 2 miles to the nearest ED. I found this really great white paper by a whole bunch of federal agencies, and this quote just really summed it up to me, so I put it in here verbatim. But when someone calls 911 for a non-acute event, there's a financial incentive for those suppliers to transport them to the ED when alternative care by EMS providers could result in higher quality patient-centered care at significantly lower cost. And that was really sort of the crux of it. And I found that absolutely fascinating. Next slide, please. So EMS, of course, did begin as a transport service. Folks would come and they would take you to where they could care for you. However, modern medicine has allowed us to do quite a bit more within the scope of ambulance care and providers. So there are today many emergency conditions that can be safely and effectively treated without transport anywhere or with transport to a lower acuity setting than the emergency room. And these options are often called, there's the treat no transport or treat in place, which of course then become acronyms of TNT or TIP because it's healthcare and that's sort of what we do. However, EMS providers, they're not incentivized to do this because they're not going to be reimbursed for medication, for assessments, or other interventions that they might provide to a patient if they don't ultimately take them to the emergency department. So a really common example that comes up today is hypoglycemic patients that can be in a really, really critical state. However, they can also recover very quickly once provided glucose on scene and once there's a little bit of monitoring. I'll note that another increasingly common situation is in the case of drug overdose. With the advent of Narcan, folks can show up and they can reverse the effects of that opioid overdose. This isn't to say that they don't need follow-up care, but they don't necessarily need to go to the emergency department. However, these ambulance providers will receive no reimbursement if they leave the scene, even if the patient has been stabilized. Next slide. All right, so just to kind of put a pin in it, a lot of misaligned incentives here. Modern EMS can provide a lot of different services, and of the ones that I've kind of listed out down below there, the only one that yields payment is that dark blue on the far right, treatment and transport to the ED. Another factor that I found a little bit astonishing, just looking at the one on the left, response, I should have maybe labeled that, the sort of on-call nature of an ambulance. They provide critical services. When you really need an ambulance, you really need an ambulance, and there's no substitution for it. And we all expect that in our modern society, that they're going to be there on call 24/7. And yet our ambulance providers don't receive any kind of basic payment for the fact that they are always on call. And I think that's especially critical in those rural areas where that use is not quite as frequent, but the need is just as strong, possibly even more so since it's often a longer transport. Next slide. So of course, there's some collateral damage to the healthcare system as a result of this transport-only payment. We see higher use of the emergency department as a result. About 16% of ED visits arrive via a 911 response ambulance. This number is even higher when we're looking at the 65 and older population, almost 40% of those patients. There's really not very much data around ambulance information, but I will say that Medicare does have some. So we know that among Medicare beneficiaries, at least 45% of those that enter the ED via an ambulance are ultimately not admitted to the hospital, suggesting that they could have received a treatment in place or possibly been treated in a lower acuity setting. Maybe not all of them, but that inpatient level was not required. This in turn, of course, leads to unnecessary costs. The emergency department, hospitals are the most expensive site of care. If we can treat someone somewhere else, we should really try to incentivize that. So we know that of those 45% of non-admitted ED visits, that costs CMS more than $2 billion. Now, of course, we're not saying that's $2 billion they wouldn't have to spend. These are folks who need care. But if that care can be provided at a lower acuity setting, an estimate by the RAND Corporation suggested as much as $560 million or more per year could be saved through diversion of those different patients. Next slide, please. There's also another sort of outcome for those of us that are commercially insured. Medicare and Medicaid prohibit medical transport services from balance billing, which is to say sending a bill to a patient after the insurer has paid, but that's not the case for those commercially insured patients. Now here in Oregon, that actually is going to be the case. There will be a prohibition on ambulances balance billing beginning January 1st of 2026. But as of right now, commercial insurers don't cover ambulances that do treat in place. And that's a problem because if they don't cover that and the ambulance is called and they provide treatment in place, that bill is going to go to the patient who is probably not expecting that to be uncovered. So commercially insured patients can be vulnerable to those bills. And another major problem when it comes to, and this is really not just even the commercially insured, but there's this really wacky issue of medical necessity denial. Someone calls an ambulance and someone sitting in an office, this sort of drives me nuts, decides that they think it wasn't medically necessary. Well, most of us out here on the street don't have clinical training. We don't know. We know what looks like an emergency. And it's kind of a real issue that the standards for medical necessity can result in denials when something looked like a genuinely terrifying emergency. Next slide, please. All right, so returning to that modernization bill 2 for Oregon, the one which unfortunately did not pass. Now, that's really pretty disappointing because just some of the highlights that I pulled out here, this is the part of that EMS modernization that does talk about medical transportation. And I've kind of starred what I think the big one is, but part of what that bill would have required is OHA to develop reimbursement guidance for treat-in-place protocols for alternative EMS treatment destinations and payment for those services that would save us money, that would make the ED the site for truly emergency care and allow treatment in the most appropriate location, as well as expanding data, which is something that is sorely needed in this space. Next slide. We'll note that Medicare did attempt to do a model related to emergency transport. This launched in 2021 called the Emergency Triage, Treat, and Transport Demonstration Model. This allowed ambulance providers to partner with qualified healthcare practitioners to do treat in place as well as transport to alternative destinations. However, this was meant to be a 5-year demonstration. They ended it after just 3 years due to what was really pretty low participation overall. Of the providers, only 70% used one of these. And in truth, there's a really fascinating kind of 2-page summary, and it demonstrates that, you know, of the, sort of 147, there were about 8 of those providers that use this extensively, and everyone else did just a handful of interventions. Now, what's really interesting is of those that did use this pretty extensively, they did demonstrate results. They were able to keep people out of the emergency department, and they were able to save money. But there were a lot of just educational barriers, a lot of concern on behalf of the ambulance providers that prevented the uptake being what they had really hoped for here. Next slide. So these are just some of my final thoughts before I let you all go here. But I think that there's real opportunity to be utilizing EMS in lots of different ways. For mobile health, expanded role to provide preventative care, follow-up care, basic treatment, other non-acute interventions. Again, for me, this somewhat goes back to that on-call aspect of needing to have them around all the time. You know, I think there are lots of ways that we are not using EMS that we really, really could. That would allow us to bring care to people who maybe do have mobility or transportation concerns, as well as providing some of that emergency care that can be treated in place or that can be deferred and sent to perhaps a clinic, urgent care, etc., a lower acuity site of care. So reimbursement reflective of the resources used to treat or transport. I think that's really important, being able to provide some of those medications that can reverse a life-threatening condition. It seems to me that's something worth being able to reimburse these folks for. And of course, there's a real need for improved data on response outcomes and costs. So that is it. I can leave it to you all for discussion, or.
Thank you, Lee. That was fantastic presentation and super interesting. So we're not going to take questions now, but if you have questions about this, if you want to discuss it further, if you want to dig a little deeper into this and bat some ideas around, when we get to the end of our third presentation, raise your hand for this group. So we will do more thorough discussion there. But we'll cover two more topics, the quality strategy and the hospital payment. And then we're going to take a break. And then when we come back, we'll break out into interest groups. So, so next we'll do quality strategy. Is that you, Lee, or is it Mimi?
This one is me, Mimi, although I am going to provide the play-by-play, sorry for the sports metaphor, and Angela and Jim are going to do the color commentary because they were helped me in the development of this topic. So if you can go on to the next slide, please. All right, so I think that quality work, I think, is fascinating. Not everyone does, and sometimes it can get a little bit dull. I will not deny that. Perhaps not as exciting as emergency transport. It sounds so much more compelling. But what I wanted to do for today, I'm going to kind of get through this agenda just in 20 minutes. So talking about what is the intent of quality work in healthcare, what are the frameworks here in the US and in other countries, what does it look like? In other words, some sample applications. What are the agencies that have oversight of this or help develop this? How is payment worked into quality? I mean, we certainly talked about that a lot, so we won't go into that too much. And then some discussion regarding recommendations. So if you will go on to the next slide, please. So Jim, I think that you're back online. So if you're here, you don't mind reading this quote because I quoted you. They put him on the spot. That's all I needed to the meeting.
Yeah, there I am.
Yay, perfect. Thanks, Jim. Maybe you could explain a little bit what you were talking about.
Yeah, I sort of took offense at that little it's boring or whatever you said. But,
about quality not necessarily being scintillating. Sorry.
Right. Quality in healthcare, when you're on the one end of accusing somebody of poor quality, that's not boring.
Good point.
Quality in healthcare and healthcare systems is one of those goals that everyone strives for, but the process of defining it, measuring it, and making change is often disputed, even contentious.
All right. I think people would agree with that. All right, can we go on to the next slide? Thank you. So when we are talking about quality, I thought this was a nice way to think about it. I didn't make it up. Institute for Healthcare Improvement did. I think everyone here is familiar with the term, experience of care, improving the health of populations and reducing the cost. People are most likely familiar, because there's a lot of providers here, with the quadruple aim, well-being of the healthcare workforce, and then the quintuple aim, advancing health equity. And so really, when we talk about quality, I think that sometimes it is easy to forget that the true nature of quality work is to assess, find out root causes, and then make improvements. In other words, to make things better. And these are the things that quality work is trying to make better. And so Jim and Angela, anytime you want to hop in, please do. Just feel free to interrupt me. Next slide.
I realize we're time constrained, so I'll keep my mouth shut.
Thanks, Jim. All right. So when we look at, again, I still think of these, although these are sort of models of ways to think about quality, this still really talks about the intent of the work. There's the Institute of Medicine one, which has been around for quite some time. World Health Organization, I think, added on something that is very beneficial when we talk about quality. And so in addition to all of those safe, effective, et cetera, hallmarks of quality work, they add in integrated care. And I think that's an essential component and something that actually can be measured and then improved upon. So next slide. So CMS has a national quality standard. As of now, the word equity is still in there, which is nice. So again, their mission, achieving optimal health and well-being for all individuals. And then you look at it and you look at the components of it, very similar to the Institute of Medicine. Next slide. All right, and this came from Jim and Angela, so I would love to have them both speak a little bit about, I think, Jim, you talked about like the perspective of quality work.
Okay, so I think the patient obviously has an interest in being treated well. And sometimes it's not always consistent with what institutions and other stakeholders have in mind. The institution, so at the patient level, it's specifically the individual intervention. At the institution, it's the collective interventions. And community is almost irregardless of interventions. What's the correct intervention? And then process, outcome, and structure are just ways of looking at it. So the structure is the building healthy. Process is, are people doing the right thing? And outcome is, did you get the results you wanted?
Yeah.
I'll let Angela do the other column.
Thanks. Yeah, I think the perspective is important because we have, healthcare, we have consumers, we have patients who, they're the ones being treated. What is their perspective of their care? And I also agree on the structure, process, and outcomes, right? Ultimately, what is the outcome, right? We can have patient-reported outcome measures, and we can also have processes like, did we deliver the screener, right? A very common process measure that we see in primary care, the depression screening. And then do we have enough nurses, doctors, workforce, on the structure side as well to really adequately provide the care. And then you can look at quality measures across the continuum, right? The measures that are appropriate for primary care are not the same ones. You're, looking at diabetes, hypertension in primary care. And then in the hospital, you want to look at CLABSI, CAUDI, the falls, SSI, surgical site infections. So I think really quality does depend on the setting as well. And then public health, how do all those different settings, what is the prevalence of diabetes in the community, right? And then do we have enough, what is the workforce and the number of clinics, et cetera, that are available, especially in rural areas? It's something to consider. We have less density. So really working in partnership with public health, and public health really having an eye on, the overall surveillance, if you will. Mimi, you worked in public health for a long time, and I just see public health being, right, kind of like, emergency transport in some ways, where they just have so many different grants that they're running on and so much that they're trying to do, some of which is direct service in addition to surveillance, so, I think, working all of the, the healthcare system working in partnership and everyone playing to their strengths is important in all of this too.
So I'd like to just chime in with an example of how these can be at odds with each other. A few years ago, and so this affects me personally, they came out with a recommendation that people might, like myself, not be tested for PSA, because it led to a lot of unnecessary procedures that actually harmed patients. And I had engaged in extensive conversations with my doctor on this topic. And, I was willing to go along with that, but Apparently, most of her patients were not. Because at a public health level, this was costing money, and the cumulative negative effects didn't outweigh the benefit. But when it's your prostate you're talking about, people have a different attitude.
Absolutely. Thank you both. Next slide, please. All right, I promise I'm not going to read this, but there's different types of quality measures. CMS has a nice listing of them, and I think Angela mentioned sort of patient-reported outcomes are one of the things that are looked at. I like the difference between outcomes and intermediate outcomes. As you can see, what we're really getting at is there are so many different ways to look at quality, and if you can sort of think of it divided up, either by outcomes or who's doing the reporting or who is being affected. Next slide, please. I put a couple of international frameworks. One was from Australia, the other one was from New Zealand. They just have a different way of framing it. I thought the determinants of health in the Australian system was interesting, with health behaviors, personal biomedical factors, then socioeconomic factors being one of the ways that they divided things up. I think in New Zealand too, they have enabling the workforces as improvers. So that sort of is our quadruple aim, I think. But then they also have sort of how the health services are divided up. So again, just different ways to divide it and to look at quality measures and quality work. Next slide, please. Here's more of that. Again, it can not only be divided by domain, but also by condition, by the data source, or as Angela mentioned too, by the clinical setting. Next slide. Right. Lee actually found this information. So this is from the Oregon Quality Measures Selection Criteria, and I thought it was very useful. So when one is thinking about a specific measure, so we'll give the example, let's say you wanted to pick a quality improvement metric that would apply to all of the CCOs, and this is sort of how they look at the quality of that measure itself. So is it evidence-based? Are there benchmarks? Is it not overly influenced by case mix? So in other words, from region to region, would you expect similar outcomes? Is it relevant to what you're trying to do? In other words, does this matter in the ultimate impact for the individuals or the population? Is it feasible and not overly burdensome? I can just feel the eye rolls from providers coming my way about the not overly burdensome, because sometimes they are. Does it align with other quality sets? Is there an opportunity for improvement? Again, this is sometimes I think forgotten in the quality work, is that really the idea is for improvement. And then again, are there enough events in what you're measuring to have a sufficient size for the information to be reproducible or to be effective? Next slide, please. All right, this is one of those samples, as I mentioned. So if you're for quality work within a hospital, and just as Angela mentioned, there's lots of different names for things, but you can see how you got the area, so it's within the hospital, looking at it in all these different ways, and then the specific measures are what you see. You can also notice how many of them there are, and that's just a handful of what is actually available. There are literally hundreds of measures. Next slide, please. All right, this one, I found this and I did think that it was useful as a way to put all of these sort of different facets of looking at quality together. So if you look at the dimensions of quality, those are the ones that we were talking about right at the beginning: safety, effectiveness, patient-centeredness. The functions of healthcare is how it's described here, but again, that was sort of the continuum of care in one of our other slides. What types of activities are the strategies, different setting standards, monitoring, the Dunabedian's triad of structure, process, outcomes, in other words, types, the format in which things are measured, and then just the targets. What is trying to be changed? Is it work from health professionals? Is it work from the payer side that needs to be different? So again, I thought that this lens, being able to perhaps as we go along further and you all are thinking about what this committee would like to comment on and how they think healthcare strategy should be brought about, I think this is a useful framework. Next slide. All right, and just again, national quality agencies, we can go on to the next one. In Oregon, people may be aware, especially those in primary care, about the work of the Metrics and Scoring Committee, but also it goes beyond primary care, and the Health Plan Quality and Metrics Committee. So they identify the measures that can be applied to CCOs. They can be used by other health plans as well. Frequently, these measures are ones that are already national standards, for example, HEDIS measures. This committee, that was this slide that had sort of the different ways of choosing a specific measure. That is the criteria that they use for choosing measures. Again, sorry, because it's a little bit small, but if you look on the right-hand side and you see number of measures, there are a lot. Next, please. All right, and then again, payment programs, we've talked a lot about this. Medicare has them, Medicaid has them, commercial certainly has them as well. So I'm just going to go on to the next slide. All right, and so I think we might even end 2 minutes ahead of time, which is exciting. So what I am hoping, and I hope Angela and Jim will also chime in on this, is the work of this committee is to comment upon and provide direction for a quality strategy. And so kind of thinking about the scope of that, as we said, that doesn't mean that we're going to pick the top 10 metrics and say, do this, right? So I think sort of coalescing on what is the intent of the work, what are the core dimensions, what types of activities should be monitored, and then making sure that it is throughout that continuum of care. So I'm going to stop now, but let Angela and Jim kind of add in any more thoughts about that. Oh, and thank you. I'm sorry, I'm just going to read something from the chat. Jamie said, I think equity is now also included in the Oregon model for metric selection. Thank you, Jamie.
I think one thing that you need to think about is how you incentivize quality. And is that even possible?
Excellent. So within the scope, yes, how quality is incentivized. I think that's and I think that is an excellent point to add to the discussion.
Yeah, thank you very much, Mimi, for this. It's a really great overview. And yeah, I'll just underline, Mimi just said this, but I'll underline, if you want to dig deeper into this, the goal would not be to think about metrics. The goal is more of, in a universal health plan, when some of the equity issues might be addressed by covering everybody and not having differences in access based on who's paying for your care. How would you approach a quality strategy? This will be an initial discussion to just think through what your experience has been of quality strategies that you've worked with, what you think is worth holding on to, how we would build a quality strategy for the UHP and just get the ball rolling. So if you're interested in that, you can join that breakout group. And these 4 points here that on this slide are really great ones for that small group to start with. Cool. Thank you so much. And then we have one more quick conversation about hospital payments, talking about the Maryland strategy. And I'll hand it over to Lee for that. I'll remind the committee that the legislation that created this board asked us to approach hospital payments as global budgets. So that is something that we're obligated to sort of explore, is how would that function if we paid hospitals based on global budgets. But the experience in Maryland also has a lot of teachings for us. And so I'll hand it over to Lee.
All right, and this will be pretty short. Mostly what I'm seeking here is feedback from all of you. So to the extent that we want to move along, we can certainly I invite people to join me in the breakout room. So just a quick refresher, I mentioned Maryland last time when I did the initial overview on hospital payments. But currently in Maryland, all 43 of their hospitals, community hospitals to academic medical centers, are under global budgets. They've been under global budgets for a little over 10 years now. I will note Maryland is a fairly urban state. It does not have any critical access hospitals. So definitely some key differences to note there. They base
It does
those
have sole provider hospitals, though.
Possibly, I would have to check on that, but certainly no rural districts or no frontier counties such as we have in Oregon. Those initial budgets were based on revenues from the prior year with adjustments for service mix, population, uncompensated care, etc. It covers all those services at the hospital with the notable exception that they do not include physician services provided at the hospital within that global budget. And they allow for hospitals to petition for some extra if they have capital expenditures coming. They can do that for the following year. And really, my question for the committee, there was a lot of interest in knowing more about Maryland's system. Before I dive in, would just love to know kind of what are some of those specific questions that you have, or what particularly intrigued you, so I can focus and come back with, what's really going to be most relevant to your decision making.
Yeah, so if you're interested in diving more into what does that look like to pay hospitals with a global budget, and how would that work? What are the implications of that? What are the pros and cons of the model? And want to think more and talk more about that. That would be the third area to do as a breakout group. So we are going to take a break, unless Lee, you had anything more on hospital? Okay. We're going to take a 10-minute break, but before we leave on break, we're going to try and figure out which members of the committee want to discuss which topics. And then during the break, our fabulous administrative support person, Isabel, will get us all into breakout rooms for when we come back. So when we come back, Isabel, do we all join the main room, or are we joining right away the small group room?
We'll come back, and then I'll open up breakout rooms, and committee members, you will go into the room you've indicated, and I will assign you to, and members of the public will be able to self-select which rooms they would like to. They can go to one room, move between the rooms, stay in the main room, whatever you'd like for the
Okay. And then we'll reconvene in the main room at the end for members of the public and for wrap-up committee business. Okay, so when we split up into groups, there might be one big group. If we all want to talk about the same topic, there might be two, or there might be three. So the topics are emergency transportation, a quality strategy, and hospital payments. And we're going to indicate by chat. You can put in the chat which group you would like to be part of. And I would remind everybody that each small group really needs to identify a note taker who will take notes and then submit those to Isabel at the end of your session. And it could be the same person or a different person will be responsible for report out when we gather back together. Those are super important roles. We have no way of tracking what you talked about unless somebody takes notes. So those are really important. Okay, and everybody has access to the chat, and I see folks putting in there what they're interested in. If everybody could put their preference in the chat, and we'll make sure we have everybody. A lot of folks for quality. So far, 3 of us in transportation, 1 person in hospital. 2 in hospitals. Awesome. Yay. Looks great. And if people have questions about what these groups will be talking about, you can pose those now if you need more clarification. So the folks, when you're saying you're flexible, you just want Isabel to assign you randomly, or because she will, we will give her that power to just put you randomly somewhere. Okay, cool. Cool. Do we have everybody? Has everyone been accounted for?
I believe so. Helen, what group would you like to be in?
I put transportation.
Okay, perfect.
Yeah.
I see you now. Thanks.
Okay, excellent. Then it is 2:35, perfect timing. We're going to take a 10-minute break. We're going to reconvene back here to the main room at 2:45. Thanks, everyone. Okay, everyone, welcome back. We are going to make sure folks are mostly back here. I'll say this again, but we're going to break out into our small groups, and we're going to have 40 minutes of discussion in the small groups, and then we will reconvene for a report out after that. And so that means roughly 3:30. Is that right? That we will send folks to a breakout room, and then we will pull back into the big group at 3:30. Is that right, Isabel?
That works.
Okay, cool. So Isabel's going to start dividing us. Before she does that, quick reminder, first thing you need to do is choose a note taker and somebody to do report out. And then we'll all get bumped back to the main room at 3:30. So please watch the time. So Isabel, you can take it away.
Sounds good. I'm going to open up the rooms, and as a reminder to members of the public, you're free to join whichever room you'd like. So with that, I'm going to open you all up, and you should be whisked away.
It's always alarming to get transported like that.
Jim said we were going poof.
Exactly. That's what it feels like. You just kind of just vaporize. Okay. Do we have everybody back?
Yes.
Great. Then we've got about 20 minutes to do some report outs and next steps. So I'll call on the quality group. Why don't you tell us what you guys talked about, what you came up with?
Hang on for 1 second, and I'm going to share my screen, but thankfully, Jamie is going to do the talking. So apologies for the teeny tiny writing, but this is more of a prompt about what we were talking about. So yeah, don't try and read this. Poor Jamie has to.
So one of the main things we talked about was that first, structure, process, outcome things, and that even though Oregon is very aspirational, we're not going to rise to the aspirations of quality. We're going to sink to the level of our systems. And so making sure that we have proper structure and systems in place underneath whatever is developed as a quality program. And just recognizing that as a state, one of our superpowers weaknesses is we think we can do something really creative better, and we invent our own metric, but we don't really create the infrastructure to support it. So we are begging for the system to be trustworthy, simple, reducing the volume of metrics, reducing the number of homegrown, weird, unique things that are really hard to operationalize or practice or measure. Keeping it very patient-oriented, rather than, there's a patient in here somewhere, there's a clicky box in here somewhere, trying to keep the connection between the processes and outcomes that we're hoping for and the people that we're serving. with those. We were very impressed with how New Zealand is so transparent with this. Like, you can go to their national website, click on an area, and drill down to effectiveness, patient-centered equity, access, efficiency. Like, you can drill down to it in such a beautiful, transparent way. So there's some really nice models on how we might envision this. We are noting that solutions that are already available to us that we might want to rely on. There's a person-centered primary care metric, which is 11 items that measures primary care, which is really actually what saves lives. You know, good public health, good primary care, good preventive services. That's what saves lives, not how many stents can we shove in somebody's heart. And the PC-PCH structure that the state always also uses has many of those things embedded into it. So we might be able to use some of those existing structures rather than piling on hundreds of metrics on top of primary care offices or regional entities, and simplify that piece down if we have universal access, which would be great. The other thought that we wanted to throw in is that we have an opportunity to take the long game when we're developing quality metrics, rather than, again, measuring the thickness of my toenails. What was my sugar measurement today? But actually, what's the all-cause mortality of our population of diabetics who have these comorbid diseases? And how can we affect that over time? Backing up cancer prevention to vaccination. You know, like, so HPV vaccination and doing the long game of, we're trying to prevent cancer 30 years from now, because patient isn't changing from different insurance companies. We can actually incentivize the things that promote long-term health gains. We wanted to make sure that each setting of healthcare delivery might be engaged in its own development of its quality processes and outcomes and structures that they need to maintain them. And that we would like, not just recognizing that there's a kind of a hierarchy of measures, but also wanting there to be like making sure that the individual level interventions feed up into the rewards that the care systems get for taking care of those things, feed into the goals that the state has for quality, feeds into like the long game of how we reduce all-cause mortality and increase longevity and reduce unnecessary burden of illness. And that's going to mean pulling not just hospitals and primary care into the quality system, but also public health structures and behavioral health structures and social support structures into that same quality infrastructure. Otherwise, we're pulling against each other for dollars instead of working together to achieve the final outcome. All right, guys, did I hit them big things, or did I miss anything that you want me to add?
I think you did amazingly well with my terrible notes. I think one of the things that a couple other things about appropriate benchmarks. So in other words, not punishing good work, like, oh, that's great. You vaccinated 99.9%. Now it has to be 99.999%, that sort of thing was something. And also, again, we talked about, or Jamie mentioned, like the long game timeline, but there's also even just the short turnaround timeline. Like, you cannot create a metric and then expect it to be rolled out and people to be responsible for outcomes in 6 months or a year or what have you. I think that was another thing. And let's see, so.
Oh, thank you, Mimi. I had totally not looked at the whole slide. So the other piece was that bright spotting. Like, when we talked a bit about carrot and stick, and what happens in a system that loses the stick of malpractice. So we need to look at other models outside the United States that don't have our crazy malpractice thing, or look at models within the United States like the FQHC or the Department of Defense system that minimizes malpractice risk and cost, and thinking about how that could roll into sustaining a quality program. Because if we can decrease the stupid ass money that goes toward that whole, supporting that whole crazy system of medical malpractice, that money could be put into public health and primary care and quality infrastructures that could really do some way better things than this reactive negative model that we have currently. And along with that, like, innovate for quality, don't punish great success, like down with the Minnesota method. You always have to keep aspiring to do better. That's fine to help somebody get to a benchmark, but then like let people innovate and bright spot those and synergize those efforts. We also had several people say that trustworthiness of the data is really important. So just one more plug for transparency there.
Great. Thank you so much, Jamie. Transportation, I'll pass it to Eve for that.
Yeah, so I think we had a lot of conversation about how it would be better if the system were different. And I think we also recognize that there are a lot of challenges associated with making changes to a system that is governed by, you know, as Lee put up on the screen, like 600 different agencies who all have their own elected bodies. So I think the moral of the story is that in the transition from where we are today to a universal health plan, we need to make sure that funding for EMS is preserved in terms of how much billable revenue goes to EMS today, with the hope that we could bump that up a little bit, because EMS is really on the verge of collapse in a lot of places. EMS, it does tend to be supplemented by municipal funding sources, sometimes district funding sources. So we wouldn't want to transfer all of the cost to the universal health plan, but want to make sure at least that we're not contributing further to the destabilization of that system. And then kind of once we think about how do we keep EMS stable through a transition, I think the goal would be ultimately to think about transportation as its own kind of body book of work, and maybe set of funding sources that could be tracked separately, and thinking about not only the transportation portion, but even further when people call 911, there are some states who have nurse triage right in 911 to be able to determine if a lower level transport, like taxi to an urgent care, could be possible, or an appointment with a PCP instead of sending an ambulance out. And then looking at community paramedicine, where paramedics can be compensated for providing care out in the community, as well as potentially alt and mobile crisis. Of course, we have to think about in this, because mobile crisis is a new service that's required in the state of Oregon, similar to EMS, 24/7 requirement over the full geography of the state. So just thinking about how these things integrate, and then how are we evolving the system over time to change those transport incentives and be able to serve people more out in the community, or get them hooked up to the right resource when what they're experiencing is not a medical emergency. I think there was also some good conversation about how could we expand our view of this to include community health workers or other mobile healthcare workers over time, to create a system that works better for everyone, more from a public health standpoint, and also an acknowledgement and recognition that that's probably pretty far out from the actual transition from the universal, to a universal health plan, and that we would have to set this up in stages. And I know that I certainly offered to continue conversation about this. Helen did as well. So we'll be having more conversation about what this could look like. And would love to just invite any of the other members of my group to weigh in on anything I missed.
That was great. Thanks, Eve. Pash or Max, did you want to add anything?
No, that was great. Thank you. Yeah, that was great.
Perfect. So then last group is hospitals. Who wants to report out?
All right. I'll do a quick report out and then let committee members chime in, as I'm sure they have probably deeper thoughts than what I managed to jot down. But got a lot of great follow-ups with respect to curiosity about Maryland, about global budgets in general, and some different thoughts about just hospital care generally. So really wanting to look into how much rural care is provided in Maryland, since that is definitely an issue here. A lot of great conversation about labor relations, how things change under a global budget with respect to managing a workforce and having that kind of workplace satisfaction of folks. Is that better? Is that worse, et cetera? Wanting to understand as well, when Maryland went through the transition, what kind of changes did they see in their hospital landscape? Did hospitals go under? Were there new ones? How in particular did academic medical centers and graduate education fare? And just, yeah, any sort of status changes that hospitals did, whether they chose to really lean into a specialty as a way to distinguish themselves, wanting to understand how hospitals responded to that change. We spent quite a bit of time talking about just the huge variation in pricing that we see between hospitals and sort of how to accommodate that, ways in which that's valid, ways in which that's not valid, providing different levels of care, needing to maybe spend more on workforce recruitment if you are in a more rural area, et cetera, need to have some of that standby capabilities, et cetera. But also noting that there can be sort of excess healthcare resources in some places where there's a lot of sort of overlapping service areas, and really wanting to understand, how much of that is necessary and how much of that is something that, a global budget maybe shouldn't be supporting. Maybe that should, come out of a budget, and how would you want to account for that? Let's see, a lot of discussion as well about just the process of negotiation, wanting some insight into how hospitals kind of negotiate some of their prices now. What are the factors that they see as their big cost drivers, and what do we need to understand then as part of setting that global budget? A lot of discussion related to transparency of pricing, wanting that to be clear, and wanting that to be, really well justified between hospitals, why there are differences, and something that can also be understood by consumers. Although kind of the counterpoint to that was, if consumers don't have any skin in the game, that can sometimes backfire in terms of the tendency in healthcare to equate cost with quality. And not wanting to have sort of an effect where people are actually going to the highest cost providers. So kind of some interesting discussion in that area about the extent to which transparency is a good thing, or needs to be paired with a little bit of skin in the game for consumers of healthcare. Talked as well about certificate of need programs. Again, kind of going back to those, what resources are needed, how much do people need to be investing in the latest medical technology, how much should we be kind of trying to moderate that and control that, wanting to understand, in particular, how does Maryland control for that sort of thing, seeing as the hospitals there do have to petition for extra capital expenditures, et cetera, as part of their budget. So some follow-ups for me to look into with Maryland in terms of how that works and some of the immediate changes that they experienced as their hospitals moved over to the global budgets. So team, if I missed anything, please chime in.
Thank you. Looks like Jim has his hand up. Jim, you're on mute.
have you been in touch, or has anybody been in touch with anyone from Maryland? And because I could probably get you some names.
That would be great. I have actually reached out to someone from Maryland, so I am going to be making some time to chat with them directly.
Okay. No, I'll let you do that then.
Always appreciate more names, though.
Great. Any other sort of overall general feedback on this meeting today, about the breakout groups, about the topics, things we definitely want to hear more about? Now's the time if you want to chime in with any comments or feedback.
Tony had his hand.
Tony?
Yeah, thanks, Helen. Appreciate that. Just follow up a little bit on the hospital stuff. Lee did a tremendous job there. I think one of the questions came up, and actually Lee asked this question is really good. Is a valid one? Is global budgets the right choice? And thinking about looking in the analysis of that, I think there are certain aspects that certainly stand out to us for cost controls, intentionally of that. We did talk a little bit about not just about Maryland too, so I don't want to think about that, looking at other countries to learn from. So just if we've been looking other ways as far as managing this system, I think there is value in evaluating some of the learning from other ways that other countries have adopted a global budget in comparison. I think that the balancing act is thinking it is a global budget or DRG in certain sectors that probably have certain rural areas that there's a reason why they're not necessarily on a global budget or on a DRG. And I think something as a foundation for this group is to learn what are the existing structures and a grounding for everybody as we look at this question. What is the existing structures of hospitals in Oregon, and what does that look like? So that was just kind of another area where we're trying to that. To your question, Helen, I really appreciated the setup today. I think some really good learning. I think the smaller groups afford more conversation and engagement. So really enjoyed that and appreciate that from staff's perspective. Really excellent presentations. I think really appreciated that. So good work to the team.
Cool. Thank you for that. And I can't see if anybody else's hand is up for general reflections. Anyone else? Cool. Okay, we have a little bit of public. Oh, sorry. Did I miss someone?
Oh, no, that was me missing. I don't see any hands either. Thank you.
Okay, good. So we have a little bit of public comment. Folks know we have a dedicated page on the Universal Health Plan Governance Board website for the PD&E committee, and written testimony is sometimes there. There is some written testimony there now from an anonymous person who is very opposed to including Medicare in the Universal Health Plan. With the basic argument, it's a long testimony. I encourage you to read it. The basic argument being they've already paid for Medicare through, payroll deductions through their whole working lives, and now to be taxed on top of that doesn't feel fair, and so they're asking that we leave Medicare out of the Universal Health Plan. And I believe we have a couple of folks in person. Is that right, Isabel?
Yes, we had 2 people sign up for public comment today. We have one of those people present right now. So with that being said, I will hand it over to Lou to share a comment.
Okay, great.
Well, hi, everybody. Good to see you. I was impressed. Can you hear me all right?
Yep.
Yes.
Okay. I was impressed with Milliman. I thought their presentation was really good. I got a kick out of the medical tourism thing. I would like to add, if they're going to look into that, maybe they should look into how many doctors would love to move and nurses would love to move to Oregon to be under a universal plan. So let's think about that. The other thing, my main thing is about emergency transportation. I was just really impressed with Lee Hastings' presentation. I was also impressed with the discussion in the breakout group. On what we might think of as the Oregon State Firefighters Council has a real lot of information on this, and maybe that could be sent over to engagement. just, taking their basic presentation and assessing it out with the council. The other thing is, and looking at the emergency transportation, there's two types. Non-emergency, but it's very necessary. A lot of that, some of that non-emergency is based on the fact that hospitals are rated at different levels, and whatever acute or whatever health thing that they cannot cover, they have to guarantee that transportation is to a hospital or area that will cover it. I was caught in that. I had a $5,000 bill that I won't go into it. One more thing before I finish is think about what effect this would have on the taxes that are being paid towards fire, towards ambulance service. Think about the savings in taxes on that too. So, hey, good work, group. That's great. Thank you.
Thanks, Lou. I appreciate it. Mimi, Isabel Lee, is there anything else? Am I missing anything? Nothing?
So,
okay, great. Well, then we will adjourn. Thank you all so much for your participation. It was a packed meeting, lots of great discussion. We really appreciate you being here and giving your time for this. And we will see you in October. Thank you.